Hi, my name's Jacob. I'm a final year medical student at Lancaster Medical School, and this is a new venture of mine. So I'm new to YouTube, and this is my first video about an introduction to ischemic heart disease. This is going to be part of the cardiology series, which I'm doing, where I'll be releasing new videos on a weekly basis. And so I appreciate any support for this channel, and hopefully you'll find it useful in helping you with complicated topics. What you might come across within medical school. Okay, so without further ado, let's start. So to understand ischemic heart disease, we first have to talk about some definitions, and it's also worth knowing that this is also known as coronary heart disease. And if I just put my laser pointer on, just give me a second, you can see that we have the left coronary artery and the right coronary artery, along with their individual branches. And the definition is when the perfusion, so the blood flow the blood flow to the epicardium and the myocardium is reduced due to fatty substance buildup within the coronary vessels, and this is a chronic process known as atherosclerosis, and this happens over several years. And coronary means crown-like. You can remember that by thinking, the coronary arteries sit on top, almost like a crown on a king's head. Okay, so the next thing we need to talk about modifiable and non-modifiable risk factors. So I think we'll talk about modifiable risk factors first. These are risk factors which you can change, whereas non-modifiable risk factors, unfortunately, you can't change. So modifiable risk factors include dyslipidemia, so deranged levels of cholesterol within the blood. Particularly, you have elevated levels of low density lipoprotein. This is known as the bad cholesterol to the layperson. And then you might have high levels of free fatty acids, hypertension, smoking. And smoking is the most important modifiable risk factor, because your risk of having a cardiovascular event halves after a year of stopping smoking. And then other factors include obesity, physical inactivity, and mental stress. So let's talk about some of the modifiable risk factors now. So age, unfortunately, you can't slow or stop the aging process. Family history, so conditions such as familial hypercholesterolemia, dyslipidemia, and then ethnicity. So there's a higher prevalence of type 2 diabetes, mellitus, and hypertension in South Asian, African, and Caribbean people. So we can talk a little bit about the pathophysiology now. So I've created a schematic to help you understand this, almost like a flow diagram. And then we have a diagram on the right here, which shows the process of atherosclerosis happening over a couple of decades. And we're going from this initial lesion to having a complicated lesion with all these in-between steps, which I'm going to talk about now in more detail. So initially, you have endothelial damage. So the endothelium is the innermost layer within the coronary arteries, and this becomes damaged. And because of this, there's reduced nitric oxide production, which normally acts as a vasodilator of the coronary arteries, so that helps to maintain this the good blood flow. And what we have is we have these cells called macrophages or macrophages, and these enter this damaged space and they engulf. So engulf means to take in. So they take things into their cell cytoplasm, and they take things in such as free fats and other lipids. And when they do this, they release all sorts of different chemokines, cell growth factors, free radicals, which are quite dangerous, and also other adhesive molecules. So at this stage, we have so we're past the intermediate lesion, and we're starting to see this atheroma form, where we have an accumulation of intracellular lipids, and we also have this lipid core, and you can see here all this fatty lipid core. And the result of all this is these cells called foam cells. So the foam cells contain all this dead lipid material, and they also contain smooth muscle cells. So you have the smooth muscle cells and the dead lipid material within these macrophages, and this is known as foam cells. And what happens at this point in terms of plaque formation is you have the smooth muscle cells are able to lay a thin layer of collagen. So if you look where my pointer is, you have a layer of collagen here, and then here as well, and then that helps to stabilize the plaque. But the problem hasn't been quite dealt with, and there's other complications which can arise from this. The plaque can actually rupture because of the continuous flow of inflammatory cells into that region of the vessel. These inflammatory cells can also release proteolytic enzymes, so you can have degrading of the fibrous cap, and also these smooth muscle cells start to die too, and this is known as apoptosis. I can speak about this in other videos, but essentially it means controlled cell death. And complications what can arise include thrombosis, so that's the formation of a blood clot within the coronary vessel, and that's bad because you have blood stasis, and the actual flow of blood to the epicardium and myocardium is reduced. Therefore, it's being deprived of its oxygen, what it needs to pump, what the heart muscle needs to pump blood around the body. And then you can also have hemorrhage happening too, which essentially just means bleeding. So I hope that was quite a lot. That was quite a lot of information to take in, but I hope it makes sense. So let's move on. So now we need to talk about the clinical presentation of ischemic heart disease. And before I talk about this, like I said, this is my first video within the cardiology series, and I'm looking to do future videos on the different clinical presentations in more detail, particularly including investigations and management. But let's just focus on this for now. So the main symptom patients can present with as a result of this process is chest pain, and this can happen due to various reasons. So the first one is stable angina, and this is sudden onset chest pain, which can resolve with rest or with GTN spray. GTN spray is glycerol trinitrate spray, and that helps to dilate the coronary arteries, improving the blood flow to that muscle layer and getting more oxygen to the muscle layer. And the pain associated with stable angina should typically resolve within 5 minutes. Next, we have acute coronary syndrome, which includes conditions such as unstable angina, non-ST elevation myocardial infarction, an NSTEMI, or an ST elevation myocardial infarction, a STEMI. And it's important that you're aware of some of the symptoms what patients might report. So this too can present with chest pain in the form of a heaviness behind the sternum, which can radiate, so move to the jaw, the neck, or typically the left arm. And this pain sensation is transferred by sympathetic afferent nerves from the cardiac plexus. Other symptoms patients might report is diaphoresis, known as sweating, dyspnea, syncope. They might have had an episode of vomiting. And if I were to look at a patient with ACS, they might look quite pale. So the severity of the symptoms relates to the degree of vessel occlusion. In something like stable angina, roughly 50% of the vessel is occluded. In unstable angina, it's more like 70% vessel occlusion. And then in NSTEMI and STEMI, typically 100% vessel occlusion. But NSTEMI and STEMI, they can have quite variable presentations. And you can differentiate between the two by doing an electrocardiogram and looking at some blood tests too, which I'm going to discuss when I talk about them more specifically. Okay, and you typically have a thrombus formation. Remember when I was talking about the thrombus being the blood clot in the coronary arteries? When you have a STEMI, so typically when you have a STEMI, you're going to have some thrombus formation. Okay, so what we need to talk about now, we need to talk about the NHS Health Check. So this is a check offered to adults between 40 to 74 years, and this because they can have these every 5 years basically, and it's to try and pick up some of these risk factors and address them soon before the patient has any of the problems what I've just talked about. Okay, and they take place in a local GP or pharmacy, and exactly what I've been talking about. So they used to pick up early signs of heart disease, diabetes, kidney disease, and stroke. And then over 65s are also made aware of the signs and symptoms of dementia. So some of the checks, what they do, so they measure height and weight, blood pressure, and then also the cholesterol levels. And then I might give some lifestyle advice on improving diet and also improving their exercise routines is a good start. Well, a GP might consider starting a medication called a statin, which helps to lower the levels of the LDL, the bad cholesterol. And it also gives some advice on weight loss and stopping smoking. Remember, going back to earlier in the video when I was talking about smoking being the most important modifiable risk factor in ischemic heart disease. Okay, so thanks for listening. Like I said, this is just my first video, and hopefully there'll be many more to come. And I'll be releasing new videos on a weekly basis for this cardiology this cardiology series. And I also just wanted to mention that whilst I've been at medical school, I've made a lot of notes based on the different resources what I've come across. And if you have a look at my profile on YouTube, I've got a link to my my PayHip website, and on that you're able to access these notes which I've put together, over quite a long time. I've put a lot of effort into these notes, and hopefully you might find them useful during your time at medical school. Whether you're just learning a new topic, or whether you're really studying hard for exams. So that concludes the video today. Remember to like and subscribe, and stay tuned for future videos. Okay.